Hello, everybody. I'm Dr. Shishir, and I shall be giving you some brief insight on post-cataract surgery endophthalmitis, which is one of the most devastating complication a surgeon can face after doing a good cataract surgery. So the incidence of post-cataract surgery endophthalmitis ranges from 0.02 to 0.26%. You can have an acute presentation, a subacute presentation, or a chronic presentation. If the patient presents usually within 2 to 4 days with symptoms, then it's an acute presentation. And the organism we have to suspect is Staphylococcus or Streptococcus or even gram-negative bacilli like Pseudomonas, which is very fulminant. If it's a subacute presentation, which happens usually 5 to 7 days, then you have to suspect commensal of the eye, which is Staphylococcus epidermidis. And when the presentation happens after 6 weeks, it's considered chronic. And there you have to suspect organisms like a fungal or even a propionibacterium, which usually tends to sequester within the bag. The risk factors for endophthalmitis includes clear corneal incisions, non-usage of intracameral antibiotics, more intraoperative manipulation and complications like PCR, even age more than 85 years or presence of coexisting comorbidities like diabetes, all and socioeconomic status. They all increase the risk of having endophthalmitis. A clinical assessment is extremely important. You have to differentiate endophthalmitis from postoperative uveitis and TAS. TAS will have more of an anterior segment involvement. So when the patient presents with lid edema, circumcorneal congestion, or a steamy cornea, presence of hypopyon, cells flare, and presence of exudates on the intraocular lens, you have to suspect endophthalmitis. You have to evaluate the view to the fundus and grade the view to the fundus accordingly. If there is no view to the fundus, a B scan is what is going to guide you. Sometimes you can have view to the fundus and you can see presence of anterior or posterior vitreous cells or presence of some exudates, which could be whitish in the vitreous cavity. Sometimes fulminant organisms like Pseudomonas tend to have corneal involvement, and thus they tend to have poorer prognosis. Fungal endophthalmitis or propionibacterium usually tend to be chronic, and they have less external features, less of circumcorneal congestion. They'll have subtle hypopyon. The media will be relatively clear, but however, in the fundus, you can get small of these whitish exudates, which are like a string of pearl appearance. Coming to the primary management, once you're absolutely sure that it's endophthalmitis, you have to document all the positive and negative findings. Admit the patient after discussion with the relatives. Start them on topical antibiotics, low-dose steroids, dilating drops, as well as anti-glaucoma medications if required. B-scan will help you in guiding your decision on whether to intervene surgically. So based on the clinical assessment and ultrasound, once you're sure that it's endophthalmitis and a vitreoretinal surgeon has taken over the case, you will do an AC tap along with a vitreous tap or biopsy and send the aspirate for culture. Depending on the severity of the infection, you can opt for an intravitreal injection of antibiotics, and following which the patient needs to be observed for the first 24 to 36 hours, close monitoring, and he need to be on adjuvant treatment with topical antibiotics as well as systemic antibiotics. After the first 24 hours, we can decide on a repeat intravitreal injection based on the culture report. If there is improvement, intravitreal injection can be repeated. If there is no improvement, then probably you need to take the patient up for pars plana vitrectomy, where we'll do a thorough core vitrectomy. And after the core vitrectomy, we'll inject intravitreal antibiotics towards the end of surgery, following which again the patient will be on adjuvant medical treatment with topical and systemic antibiotics and will be monitored closely. If there is no improvement, then only a repeat vitrectomy with or without siliconal tamponade will be planned. A repeat intravitreal injection of antibiotics can be given based on the culture report. So this is the E-kit, which is the endophthalmitis kit manufactured by Orolab, which is available, consisting of antibiotic as well as drops. So these are the references which I suggest for further reading. And thank you, YOSI, for giving me this opportunity to present.